Welcome to vpod.ai, where we take a deep dive into complex topics and uncover the most important insights, giving you that shortcut to being truly well-informed. Today, we're navigating a fascinating and incredibly vital area of medicine, the intricate planning behind core needle biopsies for bone tumors, and importantly, its profound implications for preserving a patient's limb. This deep dive is proudly sponsored by Stonefly. They're your trusted solution provider and advisor in enterprise storage, backup disaster recovery, hyperconverged VMware, Hyper-V, Proxmox clusters, AI servers, SA365, that's a turnkey security appliance, and public and private cloud. You can discover more at stonefly.com. Imagine just for a second a diagnosis that could threaten a limb, and then think how a seemingly small step like a biopsy can actually make all the difference in saving it. That's the kind of extraordinary precision we're unpacking today.
Yeah, what's truly remarkable here, I think, is how a diagnostic procedure, something often seen as, fairly routine step, it transforms into this highly strategic decision. It directly dictates a patient's eligibility for limb-sparing surgery. It's really a prime example of interdisciplinary collaboration at its most critical. Every single detail in this process, from that initial suspicion right through to the final biopsy, it can genuinely alter a life's trajectory.
So let's get into this complex world of bone tumors then. When we talk about cancer in the bone, it seems absolutely crucial to understand a fundamental distinction right from the start: primary versus secondary bone cancer. Can you break that down? What sets them apart, and, well, why is that distinction so incredibly important?
That's really the cornerstone of everything we'll discuss today, because the origin story of the cancer, if you will, dictates the entire treatment strategy. So primary bone cancer, as the name suggests, actually starts directly in the bone tissue itself. It's quite rare, accounting for less than 1% of all new cancer diagnoses annually. Just to give you some perspective, in Australia, for instance, only about 300 people are diagnosed each year. It most often affects people in two pretty distinct age groups: adolescents and young adults, say age 10 to 25, and again, folks over 50. There are over 30 types, believe it or not, but for our deep dive today, we'll really focus on the three most common ones. Now, in stark contrast, you have secondary or metastatic bone cancer. This is far more prevalent. This type originates somewhere else in the body, maybe the breast, lung, prostate, renal, or thyroid cancers, and then it spreads to the bone. It's significantly more common in adults than primary bone cancer. For example, back in 2008, there were an estimated 280,000 adults in the U.S. living with metastatic cancer in their bones. So while it's common, our discussion today is really laser-focused on primary bone cancer. And that's precisely because of the unique and highly specialized surgical considerations involved in treating it, especially when the goal is, to preserve the limb. The treatment pathways for these two categories, they diverge dramatically.
That distinction really drives home the critical stakes, doesn't it? With primary bone cancers, we're talking about aiming for hopefully curative excision and limb preservation. That demands a whole different level of precision and strategic planning compared to the often palliative approach for metastatic disease. So let's identify these primary bone cancers we're most concerned with, the ones where limb preservation is such a delicate balance. What's first on the list?
Okay, the first and the most common is osteosarcoma. This cancer accounts for nearly two-thirds of all primary bone cancer cases, so it makes up about 35% of all bone cancers. At its core, it originates from malignant primitive mesenchymal cells. These are cells that differentiate into osteoblasts, the very cells responsible for building new bone. But in this case, they produce a malignant osteoid matrix, faulty bone material. Demographically, it's primarily a childhood illness. The median age of diagnosis is around 12 for girls, 16 for boys. Though we do see a smaller increase in incidence in individuals over 60, interestingly, in children, it's a bit more common in Black individuals and other racial or ethnic groups compared to white individuals. Classically, osteosarcoma develops in the metaphyses, those crucial growth plate regions of long bones, where bone formation is highly active. So nearly 60% of cases occur in the distal femur, the proximal tibia, and the proximal humerus, right around the knee and shoulder, mostly. These tumors can also form what are called skip lesions. That means the cancer can spread intraosseously within the same bone or even transarticularly across a joint. And when it metastasizes, when it spreads, it most often goes to the lungs. About 20% of patients actually present with lung metastases at diagnosis. The second most common location for metastasis is other bones, often in another arm or leg. Risk factors for osteosarcoma. Well, they include certain genetic syndromes like Li-Fraumeni syndrome and hereditary retinoblastoma, also Paget disease of bone, previous high-dose radiation therapy, and even sometimes orthopedic surgery involving metal implants. The critical insight here, I think, is how the biology of osteosarcoma, especially its origin in those active growth plates, directly informs its typical locations. This makes it a really aggressive challenge, particularly in growing children.
Right, so it's a cancer that literally emerges from the very processes of bone development.
Yeah.
That must deeply inform both detection and treatment. What about the second most common primary bone cancer?
Next up is Ewing sarcoma. This accounts for about 1/3 of the cases, maybe roughly 15% of all bone cancers. The exact cellular origin for Ewing sarcoma is, well, it's actually still unknown, though it's hypothesized to come from undifferentiated primitive neuroectodermal or neural crest cells, or perhaps more recently, from primitive stem cells. Like osteosarcoma, it primarily affects children and adolescents. Median age is around 15 years, and the risk is highest for those under 19. It's more common in males, and ethnically it's more prevalent in white and Asian populations. Now, unlike osteosarcoma, which favors the metaphysis, Ewing sarcoma typically affects the pelvis, the diaphysis, that's the main shaft of long bones like the proximal femur, humerus, and tibia, and also the ribs and the scapula. Metastasis pattern is similar to osteosarcoma, most often to lungs and other bones. The key risk factors for Ewing sarcoma involve specific translocations in chromosomes, primarily between 11 and 22, found in about 95% of cases, and also between 21 and 22 in 5–10% of cases. It's not strongly associated with hereditary cancer syndromes or congenital childhood diseases, which is interesting.
If we connect this to the bigger picture, these genetic translocations in Ewing sarcoma provide a really distinct biological fingerprint. That's crucial for diagnosis and also for exploring targeted therapies, which maybe we can touch on later. Also, the differing anatomical distributions between osteosarcoma and Ewing sarcoma, it highlights how distinct cellular origins manifest in different patterns of disease.
Okay, so a completely different genetic fingerprint, often affecting different parts of the skeleton, yet still a critical concern for limb preservation. What's the third main type?
The third most common primary bone cancer, and the least common of the three we're focusing on, is chondrosarcoma. This one is estimated to affect only about 1 in 200,000 persons, but it still makes up about 30% of bone cancers overall. Chondrosarcoma originates from malignant cartilage-producing bone tumors, specifically from chondrocytes. Demographically, this one primarily affects adults, typically between 40 to 75 years of age, slightly more common in males. It tends to occur more in the central skeleton, commonly found in the pelvis, proximal long bones, ribs, scapula, and vertebrae. Its growth is often slow-growing, though some rare types can spread aggressively. Risk factors for chondrosarcoma include the presence of benign cartilage tumors, things like enchondromas or osteochondromas, especially in conditions like multiple enchondromatosis or multiple exostosis. What's fascinating here is a distinct age demographic for chondrosarcoma. It affects older adults, unlike the pediatric focus of osteosarcoma and Ewing sarcoma. Also, its general resistance to chemotherapy, which we'll definitely delve into later, makes surgical excision with clear margins even more critical as a primary treatment. This fundamental difference really underscores the need for precise diagnostic classification from the outset.
And you also mentioned chordoma earlier, though it's less common. It forms in the spine bones. What's important for us to know about that one briefly?
Yeah, chordoma is very rare, a primary bone tumor. It forms in the bones of the spine, most commonly at the very base of the spine, the sacrum, or at the base of the skull, sometimes in the cervical spine too. Usually affects older adults, about twice as many men as women are diagnosed. But in younger people and children, it's more frequently found at the skull base or in the cervical spine. There are some genetic links. Familial chordoma has been linked to a specific TBXT gene mutation, and childhood chordoma has links to Tuberous sclerosis complex. Its location, right in the spine or skull, makes its treatment inherently very complex.
Okay, so with these different types in mind, what should people look out for? What are the red flags that might signal bone cancer, even knowing it's rare?
Well, the most common symptom, and the one that often leads to that initial investigation, is regional or localized pain. Pain in the affected bone or joint. This pain is often gradual in onset. It increases over time, can become quite severe. It might be worse at night or with activity, particularly in long bones, though sometimes it might actually be relieved by rest. It's important to note, too, this pain can sometimes mimic common musculoskeletal injuries, or even seem to start after minor trauma, which can really complicate the diagnosis. Also, nighttime pain, while definitely a concerning symptom, it's only present in a minority of cases, maybe 19–37%, something like that. So its absence doesn't rule out cancer. Other significant symptoms, soft tissue swelling. You might feel a palpable lump. It could even feel soft and warm, especially if it's in the arms or legs. There might also be stiffness or tenderness in the bone or problems moving, like walking with a limp. Less common, but important, symptoms can include unexplained fever, which can sometimes relapse in Ewing sarcoma, or just a general feeling of tiredness and weight loss. In rare but severe cases, a pathologic fracture can occur. That means the bone breaks for no known reason. Happens in about 7–8% of osteosarcoma cases. And rarely, tumors near the spine can cause symptoms like back pain, weakness, numbness, or even paralysis in the limbs because of nerve compression. It's critical, though, really critical, to emphasize that these symptoms are often vague. They can be caused by many other, far less serious conditions. However, persistent or recurrent bony pain or soft tissue swelling, especially without known trauma, or if it just doesn't resolve as you'd expect, that should absolutely prompt further investigation, starting with plain radiography and X-ray. Delays in diagnosis are unfortunately common, precisely because of the symptom overlap and the low incidence of bone cancer. And these delays, well, they can have serious consequences due to the aggressive nature of these cancers.
That's a crucial point. Persistence is key. Even if it's likely something less serious, getting it checked out if it lingers is paramount. And that brings us right to the core of this deep dive diagnosis. Given the rarity and the often non-specific symptoms, getting a timely and accurate diagnosis is absolutely paramount. So, what steps do doctors take once they suspect a bone malignancy, especially when limb preservation is potentially on the line?
Right. The diagnostic journey usually kicks off with diagnostic imaging modalities. The preferred initial imaging is plain radiography, just standard X-rays. These can show the location, size, and shape of the tumor, and also evidence of bone damage or maybe new bone growth. Common findings that raise suspicion include things like dense sclerosis that's abnormally hard, compact bone, or specific periosteal reactions. The periosteum is that thin membrane covering our bones, and certain reactions patterns that look like sunburst or onion skin are big red flags.
Sunburst and onion skin patterns, those sound very descriptive. For those of us not deep in radiology, what exactly are those, and why are they such strong indicators?
That's an excellent question. So, the periosteum, that thin membrane covering the bone. When a tumor grows aggressively underneath it, it irritates this membrane. This causes the periosteum to react by laying down new bone, but does it in very specific, often chaotic ways. The sunburst pattern literally looks like rays of sun radiating outwards from the bone surface into the soft tissues. It signifies rapid perpendicular bone formation trying to contain the tumor. The onion skin pattern, or lamellated periosteal reaction, looks like multiple thin layers of new bone, almost like the layers of an onion, laid down parallel to the bone shaft. This usually indicates cycles of tumor growth spurts, followed by brief periods of attempted containment. Both patterns are strong indicators of an aggressive process, something disturbing the normal bone environment which screams potential malignancy. X-rays are crucial for spotting these initial suspicious signs, which then definitely prompt further, more detailed imaging. Okay, so after X-rays, magnetic resonance imaging, or MRI, is generally considered superior to CT for staging bone tumors before treatment. MRI gives incredibly detailed images. It helps delineate meaning, clearly define the tumor's boundaries, and crucially, its involvement in surrounding muscle, soft tissue, and those vital neurovascular structures, nerves and blood vessels. This information is absolutely critical for planning limb salvage surgery. Then there's computed tomography, or CT, sometimes called a CA scan. This provides detailed cross-sectional pictures. CT is particularly good at demonstrating permeative cortical bone destruction. That's when the tumor starts to kind of eat through the hard outer layer of the bone, also bone erosion, and tumor matrix calcification. See if there's calcium within the tumor itself. CT is often the preferred method for actually guiding the biopsy needle, largely due to its speed and accessibility in most hospitals. It can also be combined with PE scans for biopsy planning or for evaluating lesions when maybe MRI isn't feasible for a patient. Other imaging tests that might be used include a bone scan. Here, radioactive material is injected. It collects in areas of high bone activity, which can include tumors, and it's detected by a scanner. Very useful for evaluating metastasis throughout the entire skeleton. A positron emission tomography, or PET scan, uses radioactive glucose. Cancer cells often consume more glucose than normal cells, so they light up on the scan. This helps find them and is useful for evaluating metastases and checking for tumor recurrence after treatment. An angiogram, which is an X-ray of blood vessels, can sometimes be used to show the blood supply feeding the tumor. And finally, ultrasonography. This can be used to identify vascular areas within tumors. Areas with good blood flow are more likely to yield a positive biopsy. It can also identify avascular areas, perhaps necrotic or cystic parts of the tumor, which are likely to be non-diagnostic and should ideally be avoided during biopsy. Beyond imaging, blood tests are also standard. They evaluate overall health and check other systems, things like urinalysis, ESR, erythrocyte sedimentation rate, a general marker of inflammation, liver function tests, BUN, and creatinine for kidney function. Doctors also measure levels of alkaline phosphatase and lactate dehydrogenase. High levels of these can be present in osteosarcoma or Ewing sarcoma. But it's important to remember, alkaline phosphatase levels are naturally high in growing children, so it's not a reliable indicator in that specific age group.
So imaging gives us all these invaluable clues, but the definitive step, the one that confirms it's cancer and tells us exactly what type and grade, is always the biopsy. And this, I think, is where the stakes become incredibly clear, because the biopsy itself, while absolutely necessary for diagnosis, carries significant risks if it's not executed with extreme precision and foresight. You called it a double-edged sword earlier. Can you expand on that?
Indeed. The primary purpose of the biopsy is clear. Confirm the diagnosis, establish the tumor grade, how aggressive it looks under the microscope, and ultimately direct the entire treatment plan. It can be performed using an open surgical technique or, much more commonly now, a percutaneous needle biopsy, specifically what we call a core needle biopsy. Studies have shown that core needle biopsy is nearly as accurate as open biopsy for diagnosing and staging these musculoskeletal sarcomas, but it comes with the added benefits of fewer complications and lower costs. However, this is a really critical part, the double-edged sword aspect. There's a significant risk of tumor seeding. It's been well documented that bone sarcomas can and do recur locally because tumor cells get dislodged and spread along the path the biopsy needle took. This is a major concern for core needle biopsies, particularly those performed with needles that are 16 gauge or larger, and the consequences are dire. The survival rates after a local recurrence are shockingly low, for instance, only about 29% for osteogenic sarcoma and maybe 14% for Ewing sarcoma. This leads us to an absolutely crucial principle in orthopedic oncologic surgery. The biopsy track, the path the needle took, and the immediately surrounding tissue must be removed en bloc with the main tumor at the time of the definitive resection surgery.
And en bloc means a single intact piece, correct, not disturbing it. So the biopsy site has to be planned perfectly to align with where the surgeon might need to cut later for the main surgery.
Precisely. En bloc means removing it all together as one unit, without cutting through the potentially contaminated biopsy tract. This means the biopsy site must be meticulously planned. It has to align perfectly with the potential surgical incision that the surgeon would use for the limb-sparing surgery. This careful planning allows that entire potential contamination zone, the needle tract, to be cleanly removed along with the tumor in one go. This prevents contamination of surrounding healthy tissues. Now, while fine needle aspiration, which uses much smaller 22-25 gauge needles, poses less risk of seeding, it's generally less accurate for getting a definitive diagnosis for bone lesions. It often doesn't provide enough tissue architecture for the pathologist. So it's often used as a complementary technique alongside core needle biopsy, but rarely is the sole method for primary diagnosis.
So what does this all mean for the patient? What happens if a biopsy is done incorrectly? If that critical planning, that alignment with the future surgery isn't considered, what are the real-world consequences?
The consequences of poorly planned biopsies can be severe, really devastating for the patient. First off, the surgeon might be forced to alter the planned surgical procedure. This could mean having to resect additional, potentially contaminated tissue that lies outside the initial optimal surgical plane they had planned. This isn't just about making a bigger cut. It fundamentally changes the surgery. It can lead to less attractive alternatives for the patient. For example, needing a wider field of radiation therapy if the tumor is radiosensitive, which means more healthy tissue gets irradiated. Or it significantly increases the chance of local tumor recurrence right there at the biopsy site itself. And as we just discussed, local recurrence drastically impacts survival. Beyond that, poor biopsy planning can lead directly to compromised limb function. If functionally important structures, think major nerves or blood vessels, or critical muscle groups are contaminated by tumor cells because of an incorrectly placed biopsy needle, their surgical resection might become necessary to achieve a clean margin. This can lead to an unnecessary loss of limb function, profoundly impacting a patient's mobility and quality of life, even if the cancer itself is successfully treated. And perhaps the most striking, and something we absolutely strive to avoid, are unnecessary amputations. A really significant multi-center study conducted by the Musculoskeletal Tumor Society back in 1996 found that inappropriately performed biopsies led directly to unnecessary amputations in 5% to 8% of patients with musculoskeletal tumors.
Wow, 5 to 8%.
Yes. Think about that for a moment. 5 to 8% of patients facing an amputation that might have been avoidable simply because of how the initial diagnostic biopsy was performed. That's not just a statistic. That's a life irrevocably altered, a limb lost that could potentially have been saved. The same study also revealed that 19% of patients encountered problems with their initial biopsies that forced the orthopedic oncologic surgeons to perform much more complex resections or required the patient to undergo additional chemotherapy or radiation therapy. This just increases the burden and complexity of their treatment journey. It really underscores just how incredibly critical that initial biopsy planning is. It's a stark reminder that in complex medicine like this, isolated expertise isn't enough. It's the integration of knowledge, the communication between specialties that truly matters for the patient's outcome.
That absolutely brings home the critical stakes involved. Precision is paramount. It's also clear that the ability to perform limb-sparing surgery itself has truly revolutionized the prognosis for patients with these primary bone malignancies. It sounds like a massive game changer, a real testament to medical progress.
Oh, absolutely. It's been transformative. Over the past, say, 30 years, we've seen incredible innovations in imaging, chemotherapy, and surgical techniques that have dramatically improved the prognosis for these patients. Where once amputations were, frankly, the common outcome, particularly before the 1970s when 5-year survival rates for osteosarcoma were dismal, under 20% now, orthopedic oncologic surgeons can remove bone sarcomas without amputation in the vast majority of patients. We're talking about 90% and 95% of patients with extremity osteosarcoma now avoiding amputation, and often with only limited loss of limb function, relatively speaking. This success is largely due to much improved preoperative planning, using advanced imaging like MRI, which lets us see the tumor extent much better. Also, significant advances in soft tissue and vascular surgery techniques, and hugely enhanced endoprostheses, artificial joints, and bone replacements that can replace the resected bone segment.
But then there's this surprising challenge you mentioned earlier, something that could undermine all this incredible progress. A critical knowledge gap in the general radiology community regarding biopsy planning specifically for these types of tumors. Why does this gap exist? It seems counterintuitive given the stakes.
It does seem counterintuitive, but the knowledge gap exists mainly because the need to coordinate the biopsy approach so meticulously with the surgical plan is quite unique to musculoskeletal tumors, particularly bone sarcomas. Think about biopsies in other organs: the prostate, liver, kidney, lung, colon, pancreas, thyroid, breast. The incidence of clinically significant tumor seeding along the biopsy tracts in those organs is generally considered low. So radiologists performing biopsies in those areas understandably prioritize other factors, usually the shortest, safest distance to the lesion, and making sure to avoid hitting vital structures like major blood vessels. They don't typically have to worry about aligning the needle track with a potential future surgical incision line. This crucial distinction, this absolute necessity for alignment in bone sarcomas, isn't always widely appreciated or emphasized outside of specialized musculoskeletal oncology circles. Consequently, few articles have been published in either the radiology or orthopedics literature that really detail the correct methods for planning these bone biopsies, and those that do exist often have a limited scope or reach. This deficiency, as highlighted by the Musculoskeletal Tumor Society, leads directly to significant clinical problems, including those devastating consequences like unnecessary amputations we just discussed. The critical insight here is that a seemingly subtle lack of cross-specialty communication and understanding can have catastrophic, truly life-altering consequences for the patient.
Okay, so if that's the problem, how do we bridge this knowledge gap effectively? How do we ensure optimal patient outcomes and prevent these avoidable complications?
The answer lies squarely in two things: a highly collaborative, team-based approach, and strict adherence to anatomically based guidelines specifically designed for these procedures. The team approach, particularly the close collaboration between the radiologist performing the image-guided biopsy and the orthopedic oncologic surgeon who will potentially do the definitive surgery, is absolutely crucial, especially when dealing with primary sarcomas being considered for limb-sparing surgery, LSS. The radiologist plays a vital initial role. If they identify a solitary bone lesion on imaging, they need to decide if it falls into the possible sarcoma category. Now, with the exception of a few very specific benign lesions that have really characteristic imaging appearances, it's generally difficult to definitively exclude sarcoma based on imaging alone. So a high index of suspicion is often required. If a sarcoma is considered possible, then consultation with the orthopedic oncologic surgeon before the biopsy is essential. This cooperative planning ensures that the biopsy entry site and the entire needle pathway align perfectly with the planned plane of incision for potential future surgery. This meticulous alignment allows the biopsy tract to be easily and completely removed en bloc with the tumor during the definitive surgical resection. This prevents contamination of surrounding tissues and, critically, preserves the patient's eligibility for limb-sparing surgery. During this planning process, the radiologist must review all available cross-sectional images, MRI, CT, not just to confirm if LSS looks feasible, but also to find the ideal site within the tumor for a biopsy. You want viable tumor tissue, not just dead or cystic areas. It's incredibly important to visualize the interface between the tumor and major neurovascular bundles. Contamination of these critical nerves and blood vessels can necessitate their surgical removal, which causes major functional loss, or it might even disqualify the patient from LSS entirely. Now, if the tumor invades an adjacent muscle, that portion of the muscle will likely need to be resected, but that doesn't necessarily mean an amputation. However, if the tumor involves the joint itself, that significantly increases the surgical complexity, often necessitating a total joint replacement and arthroplasty. In terms of which imaging modalities are best for planning, well, MRI is unparalleled for delineating the tumor boundaries, showing the extent within different myofascial compartments. Those are the distinct muscle groups in our limbs, separated by tough membranes and visualizing the relationship to neurovascular structures. CT, on the other hand, is often superior for demonstrating that permeative cortical bone destruction, bone erosion, and any tumor matrix calcification. And as I mentioned, CT is generally preferred for the actual biopsy guidance because it's faster and more accessible in many settings. Ultrasonography can also be a valuable tool, sometimes used right alongside CT, to help identify those vascular areas within the tumor that are more likely to yield diagnostic tissue, or, conversely, to identify avascular areas, necrotic or cystic parts that should be avoided to prevent getting a non-diagnostic sample. Similarly, any non-enhancing areas seen on contrast-enhanced MRI or CT indicating poor blood flow likely represent necrosis or hemorrhage, should also be avoided during biopsy for the same reason. This level of detail and planning, this integration of imaging and surgical foresight, is what truly makes the difference in preserving a limb.
So the team approach is the strategy, and these precise anatomical guidelines are the tactical playbook. This is where the rubber meets the road, where literally every millimeter counts. It sounds like what we're looking for universally across all these different body parts is a safe corridor for that biopsy needle. That means constantly assessing which muscles can we safely pass through that are easily resectable later if needed, and which critical nerves or blood vessels absolutely must be avoided at all costs because nicking them means potentially losing function or even the limb itself. Let's try to make this really concrete. Imagine we're the surgical team planning a biopsy for a tumor in the distal femur metaphysis and epiphysis. You said that's a common site for osteosarcoma. How do these principles apply right there near the knee?
That's an excellent example, yes. The distal femur is unfortunately a frequent battleground for these tumors. Okay, so with the distal femoral metaphysis and epiphysis, the standard surgical incision used later for the main tumor removal can be either a lateral on the outside of the thigh or a medial on the inside approach, depending mostly on the tumor's specific location. The lateral surgical approach typically runs just anterior to or in front of the lateral intramuscular septum, LIS. The medial approach goes over the vastus medialis muscle and the adductor tubercle of the femur. Now, for the biopsy planning, you must vigilantly avoid certain structures. On the medial side, that's the superficial femoral neurovascular bundle running in the adductor canal. Posteriorly behind the knee, you absolutely must avoid the popliteal neurovascular bundle in the popliteal fossa. And critically, as you plan the needle path, you must avoid contaminating the knee joint capsule itself.
If the biopsy track violates the joint capsule, it means the entire joint is considered potentially contaminated, which would necessitate including the whole joint in the definitive surgery, requiring a total knee arthroplasty, a much more extensive operation than just removing the bone tumor. Also, be mindful of the medial and lateral superior genicular arteries that wrap around the distal femur supplying blood to the knee area. So, the recommended biopsy approach, aligning with these surgical considerations. For a lesion best approached laterally, the entry point would be just anterior to the LIS, but staying clearly lateral to the knee joint capsule. This ensures that if the surgeon needs to remove the tract later, it's contained within an area that can be resected without major functional loss. For a lesion needing a medial approach, you'd align the biopsy tract with the adductor tubercle and pass through the posteromedial portion of the vastus medialis muscle. That part of the muscle can be resected if needed without devastating consequences to knee extension.
But again, it's always essential to discuss the specific plan with the orthopedic surgeon beforehand to ensure our diagnostic efforts align perfectly with our intended surgical and reconstructive strategy. For positioning, the patient is typically supine, lying on their back, with the target leg perhaps internally or externally rotated slightly, just so the planned biopsy site faces upward on the CT table for easiest access. This really illustrates the core principle. Find the path of least functional resistance. Find the pathway that the surgeon can always remove and block later if necessary, while completely skirting those critical neurovascular structures and avoiding violation of joint spaces.
That makes the detailed anatomical planning incredibly tangible. It's not just about getting to the tumor, it's about getting there in a way that preserves the future possibilities for the patient. Okay, so beyond the approach and the carefully chosen path, the tools and techniques used in the biopsy itself must also play a significant role, right? What should we know about those specifics?
Absolutely. The technique matters greatly. When it comes to biopsy technique considerations, the needle choice itself depends on several factors: the lesion's precise location within the bone, the integrity of the overlying bone cortex, is it intact or already broken through by the tumor, and the internal consistency of the target lesion, is it hard, soft, cystic. For lesions located more than a few centimeters beneath the skin surface, using a coaxial system is highly recommended. Think of it like a guide tube or sheath. An outer cannula, the sheath, is inserted first down to the edge of the lesion. Then, multiple biopsy passes can be made with the intercutting needle through that stationary outer sheath. This minimizes repeated skin punctures and reduces the risk of contaminating multiple tissue planes along slightly different paths. It's also crucial to ensure sampling multiple sites within a lesion. This is vital to avoid getting a non-diagnostic result. If you only sample one spot, you might hit an area of necrosis dead tissue or a cystic area, which often won't contain enough viable cancer cells for the pathologist to make a definitive diagnosis. Taking cores from different areas, especially the periphery or enhancing parts seen on imaging, increases the diagnostic yield. Regarding the specific needle types, if the lesion is intramedullary, meaning it's inside the bone marrow cavity and it's covered by an intact hard bone cortex, then a biopsy needle system with a drill tip is often most effective for gaining quick and easy access through that hard outer shell. For instance, systems like the Radi-Banopti coaxial drill and biopsy needle, typically using a 14-gauge outer sheath and a 15-gauge eccentrically cutting drill tip, have been found very effective for penetrating intact cortical bone. For hard lesions, maybe they're sclerotic, very dense, calcified, ossified, or composed of intact bone trabeculae that are infiltrated with tumor cells, you need a stiff bone-cutting needle, usually at least 15 gauge in diameter, something robust enough to cut through that firm tissue. As mentioned, fine needle aspiration can sometimes complement this, especially after the bone-cutting needle has created an initial access path. In contrast, for soft lesions, which might be primarily composed of soft tissue or even fluid within the bone, standard bone-cutting needles might not capture enough tissue. They can push soft tissue aside. For these, adding vacuum suction by attaching a syringe to the bone-cutting needle hub, or sometimes substituting a dedicated soft tissue biopsy needle, like a cutting needle designed for breast or liver biopsies, combined with a vacuum syringe, can significantly increase the biopsy yield. One thing to generally avoid are spring-loaded needles, like those sometimes used for soft tissue biopsies elsewhere. They're usually insufficiently strong to reliably penetrate hard bone cortex, and in soft lesions situated right next to intact bone, there's a risk of damaging the fragile trocar tip when it hits the bone. So yes, every detail, from planning the approach based on anatomy and surgical plans to selecting the right type and size of needle and using techniques like coaxial systems and multi-site sampling, is absolutely vital for getting an accurate diagnosis safely and preserving future treatment options.
Okay, so the biopsy is done correctly, the diagnosis is confirmed, the tumor grade is established. What's the path forward then for someone facing primary bone cancer? How do these specialized teams work together?
Well, the first and arguably the most critical step after diagnosis is expedient referral to a comprehensive cancer center that has a specialized multidisciplinary team experienced in treating bone sarcomas. This single factor, getting to the right team quickly, is probably the most important element in maximizing both survival and quality of life for these patients. These teams are truly comprehensive. They typically include the primary care physician, an orthopedic surgical oncologist, a pathologist with specific expertise in bone tumors, because interpreting these biopsies requires a very specialized skill set. Pediatric oncologist if the patient is a child or adolescent, medical oncologists, radiation oncologists, rehabilitation specialists like physical and occupational therapists, specialized nurses, and social workers. This integrated approach ensures that every single aspect of the patient's care, from the complex medical treatment decisions to psychological support and long-term recovery planning, is handled by experts working together. The overarching goal for primary bone cancers is really twofold. First, to control the cancer definitively, aiming for a cure if possible. And second, to maintain the maximum possible use and function of the affected body part, usually the limb.
That collaborative effort sounds absolutely essential. So, is surgery the cornerstone of the treatment then?
Absolutely. Surgery is truly the definitive treatment for almost all primary bone cancers. The primary goal is surgical excision of the tumor with clear or negative margins. Achieving these negative margins, meaning the pathologist confirms no cancer cells are found right at the edge of the removed tissue specimen, is absolutely crucial for limiting the risk of local recurrence and subsequent metastasis. And thanks to the remarkable advances we've talked about, limb-sparing surgery, LSS, is now possible, and indeed the standard, for the vast majority of patients with tumors in the extremities. LSS involves what's called a wide local excision. The surgeon removes the tumor itself, along with the surrounding margin of normal-looking bone, muscle, and other tissue layers to ensure all the cancer cells are gone. The defect created by removing the bone is then reconstructed. This can be done using a metal implant, an endoprosthesis, or sometimes a bone graft, which can either be an allograft from a deceased donor bone bank or an autograft taken from the patient's own body, though large autografts are less common for these big resections. In some specialized centers, the patient's own removed bone segment containing the tumor can be treated with high-dose radiation outside the body to kill all the cancer cells, and then reimplanted as a form of biological reconstruction. Following LSS, patients almost always require extensive reconstructive surgery, often at the same time as the tumor removal, and then they face rigorous physical and occupational therapy, sometimes for many months or even years, to regain as much function as possible. It's important for patients to understand that even with successful LSS, there are likely to be permanent changes in the limb's appearance, its sensation, and its overall function compared to before. Now, while LSS is highly successful and the goal in most cases, amputation is still necessary sometimes, perhaps for about 1 in 10 cases, maybe slightly less now. Amputation typically becomes the necessary option when LSS is just not technically possible or oncologically safe. This might be due to extremely large tumors that encase vital neurovascular structures that cannot be sacrificed, or if those structures are severely compromised by the tumor or biopsy tract contamination. Other reasons might include a very poor response to preoperative chemotherapy, meaning the tumor didn't shrink enough, or if the tumor progresses significantly during initial treatment. However, it is significantly less common now than it was decades ago, thanks directly to the continuous advancements in limb-sparing techniques and adjuvant therapies. For tumors in other challenging locations, in the pelvis, wide local excision is still the goal, often requiring complex reconstruction with grafts or implants. For jaw or cheekbone tumors, less common primary bone sarcomas, resection and bone replacement are done, though surgery can be very challenging due to the complex facial anatomy. Sometimes chemotherapy or radiation might be the primary approach if complete surgical removal isn't feasible without unacceptable functional or cosmetic consequences. Tumors in the spine or skull, like chordoma, are also incredibly complex surgically. If complete safe resection isn't possible, a combination of chemotherapy and/or highly targeted radiation therapy is often the mainstay of treatment.
Okay, surgery is the cornerstone, but what about the other treatment modalities? You mentioned chemotherapy and radiation earlier. How do they fit into the overall strategy for tackling these complex primary bone cancers?
Right, they're often crucial components. Chemotherapy is a key player. It uses potent anti-cancer drugs, usually given intravenously, to destroy or slow the growth of cancer cells throughout the body. It's considered standard treatment for both newly diagnosed and recurrent Ewing sarcoma, and also for newly diagnosed osteosarcoma. It typically involves using a combination of several different chemotherapy drugs together. However, as we noted, chemotherapy is generally not typically used for most types of chondrosarcoma or for chordoma, as these tumor types tend to be inherently resistant to current chemotherapy agents. The timing of chemotherapy is important too. It can be given neoadjuvantly, meaning before surgery. The goals here are to shrink the primary tumor, potentially kill off any microscopic pulmonary metastases that might already be present but not yet visible on scans, and ultimately to make limb-sparing surgery more feasible and successful. Chemotherapy is also given adjuvantly, meaning after surgery. The purpose here is to eradicate any remaining cancer cells that might have been left behind locally or that may have spread elsewhere in the body, thereby reducing the risk of post-surgical metastasis and recurrence. In cases of advanced metastatic cancer, chemotherapy might be used palliatively, not aiming for cure but to control tumor growth, manage symptoms like pain, and potentially prolong life. Common drugs used for osteosarcoma include high-dose methotrexate, doxorubicin, and cisplatin, sometimes with others like etoposide and ifosfamide added depending on the protocol. For Ewing sarcoma, common drugs include cyclophosphamide, doxorubicin, etoposide, ifosfamide, and vincristine, often given in combination regimens like VDCIE. As you might expect, these are powerful drugs with significant potential side effects. Common ones include fatigue, nausea, vomiting, diarrhea, loss of appetite, hair loss, constipation, nerve damage causing numbness or tingling, neuropathy, potential hearing effects, and very importantly, an increased risk of infection due to suppression of the bone marrow. Then there's radiation therapy or radiotherapy. This uses high-energy X-rays or other types of radiation to kill cancer cells or stop them from growing. It's very often used as a key part of the treatment for Ewing sarcoma. It might even serve as an alternative to surgery if a wide surgical excision isn't possible due to tumor location or size. It's also used if there are positive surgical margins after surgery, meaning some microscopic tumor was left behind, or for tumors that are deemed unresectable. Radiation is also used to treat lung metastases from Ewing sarcoma or to manage neurological compromise resulting from spinal tumors pressing on nerves. Radiation therapy may also be used sometimes for osteosarcoma, chondrosarcoma, and chordoma, particularly if a small amount of cancer remains after surgery, positive margins, or if surgery isn't performed at all for some reason. However, it's important to note that while radiation is a major component and difference in Ewing sarcoma treatment compared to osteosarcoma, most osteosarcomas and chondrosarcomas are considered relatively radioresistant. This means radiation is less effective against them and is seldom used as the primary treatment modality for those types, though it can play a role in specific situations, often for palliative symptom control. Side effects from radiation depend on the area being treated, but can include fatigue, skin redness or soreness in the treatment field, and hair loss in that specific area. A significant concern, especially in children, is that radiation can retard future bone growth in the treated limb, and it also carries a long-term risk, albeit small, of inducing subsequent secondary cancers later in life. So its use, particularly in young patients, is always very carefully considered and weighed against the potential benefits. Beyond those mainstays, there are a couple of other techniques sometimes employed. Cryosurgery is one. This involves using liquid nitrogen to freeze and kill cancer cells. It can sometimes be used instead of or in addition to conventional surgery to destroy tumor tissue, particularly for certain benign aggressive bone tumors, or sometimes as an adjunct in sarcoma surgery. And then there's targeted therapy. This is a newer class of drugs designed to specifically interact with certain molecules known to be involved in cancer growth and survival. An example is the drug denosumab, which is approved for treating giant cell tumor of bone, another type of bone tumor, often benign but locally aggressive, that cannot be completely removed surgically. Denosumab targets a protein called ligand, helping to prevent the bone destruction caused by osteoclasts that are recruited by the tumor. Research is ongoing to find more effective targeted therapies for primary bone sarcomas as well.
This really paints a picture of a complex, multi-pronged attack. It brings us to perhaps the most crucial point for patients and their families. What's the outlook? What factors truly influence the prognosis? Understanding this is so essential for setting expectations and guiding that long-term care.
That's right, prognosis is key. For osteosarcoma and Ewing sarcoma, the single most significant indicator for prognosis is whether or not metastases, spread of the cancer, are present at the time of initial diagnosis. If the disease is localized, meaning it's confined to the primary site and hasn't detectably spread elsewhere, the 5-year survival rate is generally in the range of 70% to 80%. That's a significant improvement from decades ago. However, if the cancer is already metastasized at diagnosis, usually to the lungs or other bones, that 5-year survival rate drops dramatically, down to only about 20% to 20%. It highlights the critical importance of early detection and effective systemic treatment. Another really critical prognostic marker, particularly for osteosarcoma, is the tumor's response to neoadjuvant chemotherapy, the chemo given before surgery. After the tumor is removed, the pathologist examines it under the microscope to see how much of the tumor has been killed by the chemo.
If there's greater than 90% tumor necrosis, meaning the chemo wiped out more than 90% of the tumor cells, that's considered a good response, and is associated with a significantly increased chance of long-term survival, perhaps a 10-year survival rate improvement. So, putting it together, positive prognostic factors generally include having localized disease, especially in an extremity like an arm or leg, achieving clear surgical margins during resection, and having a good histologic response to chemotherapy. Conversely, negative factors that tend to worsen the prognosis include an incomplete surgical resection, leaving tumor behind, being older at the time of diagnosis, especially for osteosarcoma, having a poor response to chemotherapy, less than 90% necrosis, the presence of detectable metastasis at diagnosis, having the primary tumor located in the axial skeleton, like the spine or pelvis, which are harder to resect completely, and having a very large primary tumor, often defined as larger than 8 centimeters. Now, for chondrosarcoma, the situation is a bit different because, as we mentioned, it's generally resistant to chemotherapy.
Therefore, the main factor influencing prognosis is the histologic grade of the tumor, assigned by the pathologist based on how abnormal the cells look. Grade 1, or low grade, chondrosarcomas typically grow slowly and have a very favorable prognosis after adequate surgical removal, with approximately 90% long-term survival. However, for grade 3, or high-grade chondrosarcomas, which are much more aggressive, the survival rate drops significantly, perhaps to between 30% and 50%, even with surgery. Grade 2 tumors fall somewhere in between. This really underscores the importance of accurate grading from the biopsy and the critical role of complete surgical excision for chondrosarcoma.
The good news in all of this, though, is that research is constantly pushing the boundaries and offering new hope, especially for these rare and challenging cancers. Can you tell us about some of the promising new research efforts underway?
Yes, absolutely. A prime example of this ongoing effort is a major international study called the Ewing 1 trial. This is a large-scale clinical research program specifically designed to try and improve outcomes for patients with newly diagnosed Ewing sarcoma. It's a collaborative effort involving many countries. The study has several ambitious aims. First, it's seeking to determine if adding a targeted therapy drug called regorafenib to standard chemotherapy improves its effectiveness. Second, researchers are working to refine treatment protocols by trying to find the optimal dose and timing of radiotherapy for different risk groups of Ewing sarcoma patients. And third, they are investigating the potential benefit of giving additional maintenance chemotherapy cycles after the main treatment is finished, to see if that can further reduce the risk of the cancer returning. This trial is actively recruiting patients globally, including both children and adults, typically from age 2 upwards. It's a complex trial expected to run for many years, likely until around 2032, with different research questions or strands opening up over time as new data emerges and new ideas are tested. This long-term commitment in international collaboration really underscores the dedication within the medical community to find better, more effective, and potentially less toxic solutions for patients facing Ewing sarcoma worldwide.
That's incredibly encouraging to hear about that global effort. Now, while our deep dive today has really focused intensely on primary bone cancers and their unique surgical considerations, particularly around limb preservation, it feels important to briefly circle back and touch on bone metastases. As you said at the start, these are far more common in adults overall, and they present their own distinct set of challenges and, crucially, different treatment philosophies.
Indeed. It's a very important distinction to revisit. Unlike primary bone cancers, where the primary aim is often curative excision and functional limb preservation whenever possible, the treatment approach for bone metastases is overwhelmingly palliative in nature. The primary goal shifts from cure to managing symptoms, preventing complications, and improving or maintaining the patient's quality of life for as long as possible. Just to recap the distinction, bone metastases are cancer cells that originated in a primary cancer elsewhere, commonly breast, prostate, lung, kidney, or thyroid, and have spread to the bones. They are extremely common in patients who have advanced disseminated cancer from these sites. Interestingly, more than 25% of patients who have bone metastases might actually have no symptoms initially. But for the vast majority, around 75%, pain is the dominant and often debilitating symptom that brings the metastases to medical attention. So the symptoms and management goals for metastatic bone disease are primarily focused on that palliative care approach. As noted, the most common symptom is pain. This pain is often localized to the site of the metastasis, but it can sometimes radiate or be more widespread if multiple bones are involved. Depending on the location and type of bone destruction, the pain might characteristically be worse at night or with bed rest, or conversely, it might be exacerbated by activity and weight bearing. Other serious symptoms or complications that palliative care aims to prevent or manage include pathological fractures. This is where the bone, weakened by the metastasis, breaks with little or no trauma, particularly concerning in weight-bearing bones like the femur or vertebrae. Hypercalcemia, an abnormally high level of calcium in the blood released from the damaged bone, can also occur and cause symptoms like confusion, nausea, and constipation. And critically, spinal cord compression can happen if a metastasis in a vertebra grows and squeezes the spinal cord or nerve roots. This is a neurological emergency causing severe back pain, difficulty walking, progressive numbness or weakness in the legs, and potentially loss of bowel or bladder control if not treated promptly. So the overarching goals of palliative treatment are clear. Relieve pain effectively, prevent or stabilize pathological fractures, maintain the patient's activity level and mobility, preserve neurological function, and, if possible, through systemic treatments, potentially prolong survival. But again, curative intent is unfortunately rare in the setting of established bone metastases. In terms of the treatment modalities for metastatic bone disease, there are both local treatments aimed at specific symptomatic sites and systemic treatments, which treat the whole body. Local treatment primarily involves radiotherapy. External beam radiation therapy is highly effective for relieving pain from bone metastases. Significant pain relief is achieved in the majority of patients, often starting within days to weeks of treatment, and can frequently be delivered effectively as a short course, sometimes even a single treatment fraction, making it convenient for patients. Surgery for bone metastases is used much more selectively than for primary bone cancers. Its main indications are to stabilize an actual pathological fracture, or to surgically stabilize a bone with an impending fracture deemed at high risk of breaking based on its size and appearance on imaging, prophylactic fixation. Surgery is also used emergently for spinal cord compression to decompress the spinal cord and stabilize the spine. The surgical goal here is typically to remove as much tumor tissue as feasible to relieve pressure and provide stability, often with metal implants. But wide curative margins are usually not the primary objective. Postoperative radiotherapy is often given to the surgical site to help prevent local tumor regrowth if pain persists or resection was incomplete. For systemic treatment, which aims to control the cancer throughout the body, chemotherapy can be effective in treating bone metastases from certain cancer types known to be chemosensitive, like breast cancer, small cell lung cancer, lymphomas, and multiple myeloma. Pain relief from chemo typically occurs within about 10 to 14 days if the cancer responds. Endocrine therapy, or hormone therapy, is often a preferable systemic palliative modality for hormone-responsive tumors, particularly metastatic breast cancer and prostate cancer, because it often has fewer side effects than traditional chemotherapy. It can provide significant pain relief and disease control, sometimes for months or even over a year. Radioisotopes, like strontium-89 or samarium-153, are radioactive substances given intravenously that preferentially accumulate in areas of high bone turnover, like metastases. They deliver targeted radiation systemically to multiple bone lesions simultaneously and can be useful for managing widespread painful bone metastases, particularly from prostate and breast cancer. Iodine-131 is used specifically for metastatic thyroid cancer. Finally, bisphosphonates, like zoledronic acid or pamidronate, and newer agents like denosumab, which we mentioned for giant cell tumor, but it's also widely used for metastases, are drugs that inhibit bone resorption by osteoclasts. They are clinically very useful for treating hypercalcemia associated with malignancy. They can also help palliate painful bone metastases and, importantly, have been shown to reduce the frequency of skeletal-related events, like pathological fractures and the need for surgery or radiation, especially for osteolytic, bone-destroying metastases, common breast cancer, and multiple myeloma. And it's vital to remember that beyond all these medical interventions, comprehensive palliative care always includes robust supportive care, encompassing things like effective pain management with analgesics, rehabilitation services, and crucial social and psychological support for both the patient and their family navigating this difficult journey.
What a truly illuminating deep dive. We've journeyed through the complex world of bone tumors, from understanding the critical differences between primary and secondary cancers to appreciating the incredible precision needed in diagnosis and treatment, especially for limb preservation. It's just so clear that meticulous attention to detail, right from that very first biopsy, can quite literally be a limb saver.
Absolutely. I think this discussion really highlights the profound impact that specialized knowledge, advanced technology, and perhaps most importantly, truly collaborative care between different medical disciplines can have on a patient's life. For you, the listener, whether you happen to be a medical professional yourself or perhaps someone just seeking to understand more, the key takeaway is the critical importance of seeking out and relying on a coordinated, expert approach when facing complex health challenges like these. Every step, from initial symptom evaluation to the final treatment plan, truly matters. And that foresight, that careful planning we discussed, can dramatically improve outcomes and quality of life.
Couldn't agree more. Foresight and planning are key. And speaking of foresight and essential solutions, this deep dive was proudly sponsored by Stonefly. Before we wrap up, Stonefly has a special offer they wanted us to highlight for you. A 100 TB immutable and air-gapped SSO NAS, now available for just $8,995. That sounds like a really powerful and secure solution for managing critical data needs. You can find out more information at stonefly.com. Thank you so much for joining us on the deep dive. Keep learning, keep exploring the complexities around us, and we'll see you next time for another journey into what's important.